Amha, we don't have the time to give your case the full time it deserves, but I wonder if we can move to Amha's case number 4. Our experts have seen the case, they've read the case. Would you be able, Amha, just to get straight to the point with your questions, and the audience can catch up by reading the case? Would that be okay, Amha?
Yes, thank you. So this is a patient seen 8 months ago, 53 years of age, who actually was diagnosed with CML based on morphologic analysis of the bone marrow. But FISH was negative, and we repeated a qualitative PCR, which was also negative. So a diagnosis of PCR-ABL negative, or the so-called atypical CML, was made. Now we administered cytoreductive therapy because his white cell count was 53,000. And now he is stable with but developed anemia, which is transfusion dependent. So now what I would like to ask is, what is the standard approach to the so-called atypical CML?
Beppe.
Yes. Okay. I think this isn't a typical CML, but there was a PCR reversion or not?
BCR-ABL is negative.
Okay, so if BCR reversion is negative, it's certainly an atypical form of CML. And unfortunately for these cases, at the moment, it depends on the molecular defects, which is sustaining the process. So I would, in the moment, just simply to try to treat, if possible, these patients with hydroxyurea that certainly is available in your country. Because all the other drugs, more specific, depends on, first of all, on the identification of the molecular genetic defect. The second point, of course, in the variety of drug, which in most cases, however, are experimental, so investigational, and therefore they cannot be used in common clinical practice. So, and also being 53 years old, but this is not apparently an option available in your country, I think that it should be good just to try to see if there is the possibility of stem cell transplant, because for a typical CML, generally this is the best option.
Thank you, Professor. What I was thinking was, in this patient who has become actually transfusion dependent, would it be safe to consider like erythropoiesis stimulating agents such as erythropoietin? And if the white cell count increases, does not respond to hydroxyurea, because I have seen in a patient I saw some 5 years ago, he succumbed, unfortunately. So would it be like, I was thinking, we have now azacitidine in our center. So would it be safe to administer the so-called hypomethylating agents?
Yes, yes, this is a good option too. I don't think that EPO would be effective in this case because, of course, is a form, but hypomethylating agents can be used. I think that this is a very good option to do. If before using erythropoietin, please, do you have the possibility to dose the erythropoietin in the serum or not?
Not yet, but we can probably send it abroad, and we may have a report in about 10 days.
No, before administering EPO, I would try to see which is the level of EPO, which is probably already high, because the anemia is dependent on the disease and not on lack of, it's not the classical MDS. But however, azacitidine is a very good idea.
Thank you, Professor.
Any last comment there from Naeem?
Yeah, I agree with Beppe. I think it is fine. Azacitidine is a good choice. If NGS, as he already mentioned, if NGS is available, some of these genetic abnormalities can be targeted something like ruxolitinib for either JAK2 or SFCR3 abnormality. So that can be used sometimes. But overall, I think objective is to treat this patient with whatever is available. Azacitidine is a good choice. Would he be a candidate for transplant if he goes into some sort of remission? That I don't know. If his otherwise ECOG status is okay, he's otherwise fit, we can then consider transplant for him also. Because some of these cases do overlap, as mentioned by Beppe, on like an atypical CML versus undiagnosed kind of MDS, although there is no clear-cut indication of dysplasia over there from your, although it says some dysplasia, but no, it's difficult to monitor that. That's what my take on it.
Thank you. Thank you very much. We are so close to time, but there's an interesting question from Sadiq Hussein, which we'll go to. We're very close to time, but everyone's hanging in. Lanre, would you please take your slides down so Nicola can get hers back up? In the meantime, Sadiq Hussein says, can you give general advice on changing to second generation TKI where a patient does not achieve molecular targets due to suboptimal dosing and hematological toxicity? How long do you wait? Oops. How long do you wait before changing? And can you allow low dose imatinib for prolonged periods, hoping to allow cytopenias to settle / recover? Does the latter lead to potential drug resistance? Naeem and then Beppe, please. Quick comments.
Okay, it's a good question. I don't know what is the right time, but as long if I am able to, for example, imatinib, if I'm able to squeeze in at least 200 milligrams a day, and the thrombocytopenia is safe enough to continue, then I gradually go up on the dose. I keep the platelets above 50,000. I will go up by 100 milligrams of imatinib, and try not to use too low of a dose. If the dose is less than 200 milligram with significant thrombocytopenia or neutropenia, then I would consider changing or re-evaluating the patient's clinical status, whether they're still in chronic phase. But some of these patients do recover slowly on a lower dose. But the lower dose have to be careful not to leave the patient without or a very, very suboptimal dose.
Yes, absolutely. And the only thing that I totally agree with what Naeem said. I think that if available, please try to use also a thrombopad, because now I think that I've discussed also with Jorge Cortez recently with Tim Hughes and so on, and indeed they agree that a thrombopad, which is already used also in MDS, can also be used safely in CML. Of course, in order to maintain the dosage of the TKI and the correct dose, depending, of course, on the response of the patients and so on. So I think that we have to introduce also the use of L-Thrombobach in the treatment of the cases with low platelet counts in CML.
Amha and Lanre, as our African experts, would you care to comment as well?
Okay, thank you. I think this was a very interesting discussion. So we hope this kind of discussions that actually help solve problems that we face on a daily basis in our centers would continue. So I would like to thank ICMLF for organizing this, particularly Arlene and Nicola. Really, you are helping us a lot. So I am hoping that this kind of discourse will continue in the future.
We hope so too. Lanre, do you have anything to add on the question?
No, I want to thank you for this opportunity, because I mean it has answered a lot of the questions I had about those cases. So I'll follow up with them. But it would be good, as Professor Amha said, to continue these discussions so that even cases we were unable to present, we can learn about them from other expert speakers. Thank you.
Wonderful. Well, we'll get back to you in that regard really soon.
And thank you very much for involving me, Beppe and Arlene, this was really a very enjoyable
Yes.
discussion and a very fruitful thing.
It
Thank you.
won't be the last
So,
time, Naeem. So grateful. Anyway, that's definitely our time up for this session. And despite some technical problems, that was a really great session. There are a lot of outstanding issues from the first and the second discussions. There are papers to share, contacts to make, collaborations to work on. We haven't forgotten about these. I've been working on the first and the second one. I'll come back to you with a summary of all three with opportunities and suggestions to, as I say, make progress on the collaborations that we've spoken about, et cetera, et cetera. Thank you so much for your time. I'm so grateful. I'll send a summary. We will talk again soon. Thank you.